Next presentation is the last one of these sister projects. MENTUPP, Mental Health Promotion and Intervention in Occupational Settings. We have the coordinator of the project, Professor Ella Arensman from University College Cork. Ella is Professor of Public Mental Health with the School of Public Health in the University College Cork, Ireland. She is also the Vice President of the European Alliance Against Depression and past President of the International Association for Suicide Prevention and expert advisor for the WHO. So thank you so much, Professor Ella, for being here.
Yeah, thank you very much for that kind introduction, and thank you very much to Carrie and colleagues for organizing, I think, this very important and timely webinar. So on behalf of my colleagues in the MENTUPP consortium, I'm delighted to give you an update here today and to present further details. I'm also delighted that today at this webinar, we're here again with the other EU Horizon 2020 funded sister project, because it's a wonderful opportunity to connect even more, and also to see how we can collaborate in certain areas. There is an issue with enlarging my screen, so I have a quick look if I can sort that here. Yeah, but can you see the screen? Because
yeah, we can see your screen, Ella. You see down at the bottom, you've got beside notes to the right. You see yes, there to the left, a little bit to the left. If you click just beside the minus button.
Yeah, but the slight problem is that this sorry, the
yeah, you had it there. We're
there. Yeah, sorry.
There you go.
Yeah,
thank you.
Yeah, so I give you a brief update on where we are. So like all the other sister projects, we're nearly 2 years en route, with another 2 years ahead. And so we're working together with 17 partners in 13 European countries, but we're also grateful to have Australia on board, particularly with a lot of input from, some of you may have heard, the Maids in Construction, which has been really a leading mental health and suicide prevention initiative in Australia. So the MENTUPP aims are twofold. First of all, we aim to improve mental health in the workplace by developing, implementing and evaluating a multi-level intervention program whereby we target mental health difficulties with a very specific focus on depression, anxiety. And as a secondary aim, via the implementation of this intervention, we aim to reduce depressive symptoms, also impact positively on clinical depression and reduce suicidal behavior. So even before COVID-19, consistent research indicated that mental health and aspects related to well-being and stress were an increasing problem in the workplace in Europe, but also elsewhere. And with not only a huge impact on people's quality of life, but also with economic impacts in terms of absenteeism and presenteeism. Now, as with many other sister projects, we have also a specific focus on the small and medium enterprises. They represent about 90% of all companies in Europe, but have various vulnerabilities when it comes to work health safety, but specifically with a focus on mental health. Now, we do already know at this stage that under COVID-19, in certain areas and certain sectors, mental health issues, but also aspects related to suicidal behavior have been exacerbated. There are numerous examples of health, construction, and also other sectors. In the first phase of MENTUPP, particularly last year, many of our colleagues started to work on systematic reviews. And what we already had anticipated is that in some specific areas, particularly in terms of looking at randomized controlled trials related to mental health promotion projects in the workplace, or projects particularly focusing on depression and suicidal behavior, there are many gaps. So there's only a very limited extent of RCTs on which we can rely, which obviously further intensifies and underlines the priority of a project such as MENTUPP. Now, based on the limited, let's say, strong evidence in this area, what consistently comes through is that multi-level oriented interventions would have a greater impact in improving mental health in the workplace in the short term, but possibly also in the long term. So as opposed to the single level interventions that would focus, for example, only on improving mental health amongst individuals, or that would focus only at the management level. So this for us formed an important piece of evidence to take into account intensively in building the MENTUPP intervention program. Now, some of you may think, why have we selected the 3 specific work sectors here? So construction, health, and ICT. Now, interestingly, already long time before COVID-19, my colleagues and I in Ireland and also internationally found consistent evidence of high levels of absenteeism and presenteeism in these sectors, but with particularly worrying findings around high levels of suicide amongst people in construction, but also in the health sector. And that may sound a little bit paradoxical for people on the call, but this was a finding, unfortunately, consistently across many countries. There has been less research in the ICT sector when it comes to mental health, but what we have seen is overall consistent findings in terms of high levels of absenteeism, and also specific challenges related to fast speeding changes in this sector. So this really formed the rationale for us to focus on these sectors in the MENTUPP program. Then when we look at SMEs, before COVID-19, it was clear that there were many challenges, and particularly with the smaller the enterprises, the greater the challenges in terms of health and safety, but also mental health promotion. And some of the existing challenges have been further exacerbated during COVID-19. Also limited knowledge and competence in terms of resources related to mental health promotion, but also very limited financial resources to invest in mental health promotion. And then at the same time, we see that SMEs make up this huge proportion of businesses across Europe and beyond. So I think it was very important to justify our target on SMEs in the 3 different sectors. So particularly last year and in the first part of this year, my colleagues and I in MENTUPP, we have focused on further in-depth research to support the building of our MENTUPP intervention. We did a large-scale Delphi consultation across our 9 intervention countries. So we have 9 intervention countries, including Australia. There were a number of systematic reviews, some of which have been published, which further consolidated the direction of us, how best to go about building the MENTUPP intervention. In addition to that, we have checked with what for some of you will be well-known frameworks, particularly the frameworks developed by Tony Lamontagne in terms of the integrated intervention approach for workplace mental health, which we also have taken into account. Now, just briefly, we have conducted the large-scale Delphi study involving 146 experts from 9 countries, and 65 experts responded to this survey. It was an extensive survey, and interesting findings that we obtained were that 77% of the experts indicated that job stress and burnout had increased during COVID-19. Similarly, levels of depression, anxiety, and suicidal behavior. And then at the same time, this very challenging paradox of 52% capacity for SMEs to promote well-being had reduced, according to those experts. And these were experts really very closely aligned with the three sectors. Further, capacity resources for managers had reduced. And then, in terms of other outcomes, I think it was really beneficial for us to conduct this survey, which directly was feeding into the building of some of our resources. So this is the homepage of the MENTUPP Hub, and I should also outline that prior to COVID-19. We had planned that the resources and interventions that would be part of the MENTUPP Hub where we would take a blended approach, because evidence in terms of the efficacy of interventions in relation to mental health in the workplace had shown that overall the blended approach provides the stronger impacts in the short term and the long term. However, we were stuck under COVID-19. So we have put huge efforts into transforming the face-to-face interventions into online interventions, whereby for some of these interventions, we have done our best to keep interactive components as well. So when you go on the MENTUPP Hub, you will first find what we call a generic module, so where there are resources and there's information that would apply to everybody regardless of sector. And then we have sector-specific, sector-tailored resources for construction, health, and ICT. Within those resources, we also have tailored approaches for employees and for leaders, which would include the managers and the supervisors. However, once a participant is on the hub, they can access and choose where they want to go, because it's sometimes hard to determine what would have the greatest interest from people who are looking for mental health supports, and particularly interventions relating to depression, anxiety, and suicidal behavior. Here, just screenshots of the examples of what we call interactive material. So some of the modules have test vignettes whereby we ask people to choose from multiple responses. We also encourage people to engage in exercises related to mental health and well-being. And there's also a wide range of psychoeducational modules with a particular focus on depression and anxiety. What we found from previous research that peer-led resources or peer-oriented resources would be very important. So we have peer support videos whereby also people working in health, construction, and ICT provide brief testimonies. And we also have animated what we call psychoeducational videos, particularly around depression, anxiety, and suicidal behavior. When you want to reach everybody in certain sectors, certainly in the construction sector, you also may need to take into account literacy issues. So that was one of the reasons for us to also work with a blended approach of expert-oriented videos and peer-led videos. So where we are at the moment, we are on track. We are now close to finalizing what we call the MENTUPP pilot study. So in May of this year, all the 9 interventions started with piloting the feasibility and acceptability of this MENTUPP platform with SMEs in construction, health, and ICT, so across the 9 intervention countries. And just coincidentally this morning, we had our monthly plenary working meeting. So fairly soon we will be closing the access and the registration for the pilot study. And then we move into looking at our evaluation outcomes and what we call the optimization phase prior to a cluster randomized controlled trial. So I'm also very pleased to report that at the moment, in fact, from this morning on, we even have over 300 hub users in the 9 intervention countries, with about over 400 participants having completed the baseline survey. The pilot study has been extremely valuable for us in this area, and working with these sectors. It would have been impossible to immediately start with a randomized controlled trial because there's such limited evidence on what is the uptake, even the acceptability and the feasibility of interventions like this in sectors such as construction, health, and ICT. And then taking into account the ongoing challenges COVID. So with the pilot study, we won't be heavily relying on the primary outcomes, but what has been very enriching is the learning from all the feedback across those different SMEs in different countries. And you can also imagine that even though we have a standardized approach, we have standardized training for all the officers in the countries, we're also dealing with cultural and socio-economic challenges, which has been a great learning, but having prepared us very well for starting the trial in next year. So from the end of December, we will be moving in what we call the optimization phase. So we have specific work packages who have worked with us on preparing the materials. They will take into account evaluation outcomes from the pilot and start looking at enhancing and improving recruitment procedures, registration procedures for the hub, etc. And we also will have an opportunity to optimize the MENTUPP materials. So this is then lastly, very ambitiously, obviously, the design of the cluster randomized control trial that we're hoping to start in June next year. So as I say, the current pilot study has been a critical and fundamental basis to prepare us well for this ambitious endeavor. So the aim of the cluster randomized control trial is to implement in all 9 intervention countries the optimized MENTUPP intervention in the construction sector, the healthcare sector, and the ICT sector, but by randomizing SMEs in intervention SMEs and control SMEs. We then also conduct a 9-month follow-up, and also we have planned then a final 13-month follow-up. Now, overall, it's still a little bit difficult to refer to the outcomes of the pilot study, but overall, we can already say that the engagement and adherence to the MENTUPP intervention in healthcare, in ICT, is overall moving along quite well, quite positive. The interest in MENTUPP in the construction sector is very great. It's very significant, but there are many barriers and many challenges, ranging from literacy to stigma. Stigma is a huge issue in the construction, which we have weekly meetings with the officers working in the different countries, but that is really an ongoing issue. Language issues, even though we have already up to 9 translations of the MENTUPP hub, we still cannot gear to all the different languages because in construction people move around fairly quickly. But anyway, we have some time, a little bit of time, to optimize and further tailor our resources to the different sectors. So whilst we're progressing through the pilot, we have already completed some peer review publications, and then we also use what I call strategic opportunities in the year to promote mental health promotion and intervention in the workplace, but also to make people aware of MENTUPP, such as the European Depression Day, World Suicide Prevention Day and also other national important strategic days and events. I don't think there's time to go into this video, but people can access the PR video on MENTUPP, which can be accessed also via the MENTUPP website. So on this note, a big thank you again for organizing this important webinar. And I know and I have seen that our synergies with some of the other sister projects. So I think we could use those synergies to further increase capacity across Europe, I think, as a whole, in terms of improving mental health in the workplace. So thank you very much.
Thank you so much, Professor Ella. It's really nice to learn also from your experience and to see that there are some similarities between the different projects. Is there any question from the audience?
Not from the chat at the minute, no.
Mm-hmm.
I would like to make a comment just that I think it's very important to fight stigma in the workplace, because I find that that's a very huge barrier. People don't seek help because they don't want to talk about it. And I think, just as a comment, I think that's very important in all sectors really, but in some specific sectors it gets even worse. I don't know what you think about that, Ella, but I think it's very important.
It is absolutely a critical point, and that also further instigates how important the so-called multi-level approach within such interventions is. Because if you would provide, for example, only resources to employees who are already working in a sector or in an environment where stigma is very significant, they wouldn't be able to really take up or integrate those resources really in the long term, because the stigma in the environment is being reinforced by employees, but also by supervisors and also by managers. So if you want to make a difference in an organization, you have to address stigma at all levels. Now, interestingly, even though stigma is really a major challenge still in the construction sector, we have encountered, and maybe that's not coincidence, that people who know of MENTUPP in SMEs in construction who are already proactive, they will be obviously the first to contact us. So that's maybe not a coincidence, but we have seen that managers in the construction sites or SMEs, whereby they already have put in place programs to address stigma, there also staff members are more likely to be interested or come along. But it is almost a prerequisite to be able to even make a start with the intervention. Huh? So because if that is, it could be a huge barrier. Yeah.
Do you find that maybe in the construction site, it's construction sector, it's maybe has to do with gender a little bit? Maybe it's more male based, or do you think?
Yeah, to some extent. But then, for example, if we look at the healthcare sector, and I use the word, it's almost a bit paradoxical to see high rates of depression and high rates of suicide in the health sector, because you would think that people would know where to go to seek for help. But again, whether it's female healthcare workers or male healthcare workers, stigma is still very significant in the health sector as well. And it's not only stigma, it's also the kind of stereotypes that the nurse or the doctor cannot ask for help. The nurse or the doctor cannot be ill or unwell. So that's you could say that's a sector-related stereotype that we still come across very often during MENTUPP. So in one of the studies that we conducted in Ireland long time before COVID, we did unfortunately detect that suicide was very high amongst nurses, and particularly young nurses who also had received little training and certainly very limited resources in terms of self-care, and then sometimes also limited access to supervision. So this project and also some of our sister projects will also obtain a greater understanding on sector-specific stigma and stereotypes related to mental health. Yeah.
Oh, Jose Luis Ayuso wanted to.
Yes, thank you, Ella, and the rest for the talks. I mean, it's a question for you, but I mean, can be shared by the other ones. I mean, more than sister projects, we are twin projects, but we were all born the same day. That means we were all born and planned before the COVID era started. So my question is that, I mean, how did you, of course, I mean, we can imagine because we all have the same challenges in terms of the execution of the project. But my question is, what kind of adaptations did you do from the original planet in terms of the content of the interventions in order to adapt to the COVID situation, but also thinking that the workplace changed forever, probably since what happened in the last 1.5 years. So it's a question to you, but of course it's the same thing that happened to us.
Yeah. So very important, Jose Luis. Now I already indicated that, and it's still really challenging that obviously according to even the limited evidence base in this particular area, the most, or let's say the more positive and the most sustainable effects could be achieved by blended approaches in terms of face-to-face workshops and face-to-face psychoeducational sessions, which we haven't been able to do at all so far. So what we are hoping to do with come June next year is maybe to consider still the possibility to have some face-to-face opportunities with the workshops, and then obviously with the large number of intervention countries, we can then possibly also examine what are the differences when you offer such broad-based multi-level intervention online, or whether you have also opportunities for face-to-face. Another big challenge, which we still haven't been able to really address optimally, is again very much with the construction sector. So sectors where people are not so used to communicate and to get work done online, is even that first engagement and making people more comfortable in talking about mental health in a first supervisory meeting or management meeting. And we haven't had those opportunities. We had to go straight online, even in the first introductions about our project with management and with health and safety officers. So yeah, and so it also requires some improvising. Another important aspect is also even the well-being of all of us, or the partners working in area. We work with senior partners and then also early career researchers. Even the engagement within the consortium is always helped by at least some face-to-face contact. So some of our regular meetings, we have done also work in subgroups to at least connect and make sure that we're all working well and staying well in this challenging time. So improvising, making changes, and then obviously also testing any differences between face-to-face interventions and online only. Yeah.
Thank you very much.
Thank you very much. I have a very short question. Do you evaluate the presence of suicidality? And if yes, what's the strategy that you follow in case that you detect suicidal thoughts in the employees?
Yeah, so based on our baseline and follow-up questionnaires and measures, so which would be offered to all participants in all different sectors. One of several measures is the PHQ. The PHQ 9, as most people will be, the Patient Health Questionnaire, 9 items. Most people will be familiar with that. And there's an item on, specifically refers to if somebody is considering self-harm or suicide or has a plan. So we have built in a feedback loop, because again, this is all online. So whereby people who confirm that item, but we have an overall feedback loop if people also score high or higher than average on this measure, that they immediately get a feedback message automatically with recommendations for support and help, including country-specific resources as well. So you can obviously imagine that with a project like this, we had a very, very detailed ethics protocol, which we had to adhere to. Now, from the very start, ideally, because we work with 9 intervention countries, ideally we would be able to maybe consider regional changes in which we work with the SMEs in terms of self-harm or suicide, but there are not many countries with standardized systems, certainly when it comes to non-fatal self-harm. So the information on suicidal ideation is obviously a proxy for looking at any possible impacts on self-harm or suicide. Again, for the pilots, because of the numbers, we may not be able to say much about it, but hopefully in terms of the trial, we will, yeah.
Thank you so much, Sarah. Actually, we also use the PHQ 9, and we have also this item, and we follow the same strategy as you. Yeah. And of course, there is this ethical requirement, and we had to consult with our DPO and our ethics committees to see how is the best way to do it. And yeah, we follow the same strategy. So it's nice to hear.
Yeah.
So thank you so much.